Hello, people. We are getting started soon for the first hearing of AB 2200, the CalCare bill in the Assembly Health Committee. They said they're going to start right at 3 o'clock. They have a couple of the previous bills that they're up for hearing right now. Um, Hopefully, right at 3 o'clock, we officially get started. But in the meantime, we can listen in on a couple of the final bills that they have in the next couple of minutes here.
Accountable, which has been to the detriment of those receiving care and the broader community. We believe AB 2574 is a step forward in addressing cases in which licensed facilities provide services to the residents of a sober living home, but the sober living home is not included within the facility's licensure. Simply put, if residents of an unlicensed sober living home are receiving non-medical services from a licensed facility, then the sober living home is an integral part of that facility and should be regulated by the state under the facility's license. This will help ensure that a recovery residence that's operated as a business with a licensed treatment facility is regulated like businesses and not residential homes. As the number of drug and alcohol treatment facilities continues to rise in response to the state substance use crisis, the department faces a major hurdle in monitoring and regulating these facilities. With billions in the pipeline for the behavioral health housing across the state, now more than ever, we need to re-examine the oversight of these facilities and ensure that those receiving care and the surrounding communities are set up for success. Over the last decade, Cal Cities has sponsored several legislative attempts to address concerns raised by cities related to transparency and accountability for these facilities. We're continuing to focus on enacting legislative solutions that safeguard every person's well-being and care. We believe the transparency provided by AB 2574 is a step in the right direction to ensuring sober living homes that are providing services and should be licensed are on the department's radar so that we can ensure swift action. For those reasons, we believe AB 2574 will help meet our shared goals of ensuring recovery housing meets standards for patients' care, and which is central to the effective treatment outcomes and community well-being that we're all hoping for. We thank the committee for all the work on the amendments, and we urge the committee to pass this legislation. Thank you so much.
Thank you. Any additional witnesses in support? Seeing none, we'll bring forward any witnesses in opposition. Seeing none, back to committee. With that, Mr. Valencia, thank you so much for bringing this bill forward and for your work with my committee on amendments to address our concerns. I think we've struck an appropriate balance of bolstering oversight and enforcement without erecting barriers to this type of housing that is so incredibly crucial for our continuum of substance use disorder care. I know that you'll continue to work on this bill as we move forward. With that, would you like to close?
Absolutely. Thank you, Madam Chair. Ensuring that folks are receiving the health care necessary is at the core of this bill, and happy to continue those conversations. I would like to note that with the amendments that we accepted, the California Realtors Association is also removing their opposition. With that, in closing, I appreciate your time and respectfully ask for a yes vote. Thank you.
Thank you. When we establish quorum, we'll move that through. I'm going to, I know that Mr. Zuber has a very quick bill. I'm going to squeeze it in before we move to special order. AB 2613, item number 15.
Sounds like one more to go.
Please go ahead whenever you're ready, Mr. Zuber.
Thank you, Madam Chair. Very appreciative of you squeezing us in. I'm the proud author of AB 2613, a bill that creates a Rare Disease Advisory Council in California, otherwise known as RDAC. The RDAC is created in the memory of Jacqueline Marie Zabur, my sister who endured a 3-year battle with ALS, also known as Lou Gehrig's disease, and frankly, inspired me to seek public office in part to address the significant challenges people grappling with rare diseases are experiencing, as well as people grappling with a broken social safety net. With over 10,000 rare diseases affecting 1 in 10 Californians, it's difficult for state policymakers and government officials to have an in-depth understanding of the issues faced by persons affected by rare diseases and the resources needed to support them. The RDAC will be comprised of stakeholders across the rare disease community and will act as an advisory body to the legislature, facilitating consultation with experts on rare diseases in developing policy recommendations. With diverse membership and broad community support, a California RDAC will serve as a valuable resource as our healthcare system evolves. Without an RDAC, California laws and regulations that affect the rare disease community will be developed without consultation of impacted stakeholders, leaving this vulnerable population at greater risk of poor health and public policy outcomes. The creation of this RDAC will have a fiscal impact, and I'm working with stakeholders to find alternatives to state funding to alleviate this issue. Specifically, I'm in the process of conversations with UCLA, who has a rare disease center of excellence. This center offers world-class doctors in all major specialties and brings together medical teams experiencing diagnosing and treating a wide range of rare diseases, and is interested potentially in hosting this endeavor. A strong RDAC can also help relieve burdens on the state by expeditiously delivering direct feedback, solutions, and resources to policymakers with one community voice. I appreciate the committee's analysis of the bill, and I agree to accept the committee's amendments clarifying language related to the appointment of a secretary to the RDAC. You know, my sister, in the final months and year of her life, would often call me at the end of the day, just at a loss. She'd spend all day on the phone trying to figure out how to meet sort of her needs, and always wondered why our social safety net was so broken, why people with rare diseases were left out, why she would have to, she was in a wheelchair, was housebound, could not get out of the house without help and a van that allowed her to get out, because of all the, and she, we had social service programs where she would literally have to go in and wait in line and spend all day to get services that she needed. One of the last things she asked me before probably about 6 months is she basically said, Rick, I hope that you will run for office and really focus on people with rare diseases and people that need help and are experiencing just challenges with our broken social safety net. Just as my sister knew that her efforts would, not benefit her, her experience is a siren alerting us to the deeply flawed public policy approach to addressing rare diseases. Rare diseases are rare, so people have very few opportunities to sort of be at the table, and public policy is made without them. And this council will partially alleviate that. I respectfully ask for your I vote when the time comes. And with me today, I have Lindsay Vizcarra, who's the state policy manager of the National Organization for Rare Disorders, sponsor of the bill, and Michael Hu, the patient advocate, provide additional information and assist with questions.
Madam Chair and members, my name is Lindsay Vizcarra, and I'm the state policy manager at the National Organization for Rare Disorders, or NORD. I'm also a resident of California. I live up in Chico, and I'm a rare disease parent myself. 2 of my 3 children have rare diseases. I'm so pleased to be here today in support of AB 2613, which would help establish a Rare Disease Advisory Council, or RDAC, in California. For those not familiar with NORD, we're the leading independent advocacy organization in the United States, representing the more than 30 million people living with one of over 10,000 rare diseases. In the United States, a rare disease is defined as any condition that affects fewer than 200,000 people. RDACs vary in composition, in size, in housing agency and duties, but they all have the common goal of giving rare disease patients and their families a unified voice in state government. With an estimated 1 in 10 Americans living with a rare disease, it's critical that every health policy discussion, the rare disease community's unique perspective, can be considered. Rare disease patients face unique challenges every day, from obtaining an accurate diagnosis and accessing medical specialists with knowledge of their condition, to battling for fair insurance coverage of their treatment and care. I know that one firsthand. California's RDAC would help address these issues by providing a forum for stakeholders across the rare disease community knowledgeable about the needs of rare disease patients, and to help them to make recommendations to you to help the rare disease community. In addition to serving the rare disease community, the RDAC will help relieve some of the fiscal burden on the state by expeditiously delivering direct feedback, solutions, and resources to California government decision makers with regard to drug costs, research, education, and the diagnosis and treatment of rare diseases. To date, 28 states have established an RDAC. Our letter of support lists 27, but I'm thrilled to announce that Mississippi just signed the 28th into law just a couple of weeks ago. Thank you for your time, and I urge your I vote.
Madam Chair and committee members, good afternoon. My name is Mike Hu, resident of Oakland, a member of the Coalition for California Rare Disease Advisory Council, or RDAC. Thank you for the opportunity to speak with you in support of creating an RDAC in California. I'm a father of two boys, Mudong and Mohua, who are 16 and 13 years old now. They're both affected by an ultra-rare genetic disease called mucopolysaccharidosis type 2, or MPS 2. It's a systemic disease that affects every tissue and organ, which causes physical disabilities, developmental delays, and eventually leads to organ failures and deaths in early adulthood. With only about 400 diagnosed patients in the entire country, virtually no one knows about the disease, including many of their doctors. During the past 13 years battling with the rare disease, my family have experienced the many challenges that the rare disease community face every single day, from diagnostic odyssey to accessing proper medical care and therapies, battling insurance coverage, public school placement, obtaining regional center support, just to name a few. As a rare disease family, we must educate everyone who come to interact with my boys and to advocate for every bit of resource and support they need. In our great state of California, it was estimated that 1 out of 10 individuals live with a rare disease. Our goal is for the RDAC to raise awareness about rare disorders, provide valuable information and knowledge to policymakers, and to become a resource to individuals and families like ours, as well as to medical providers who support these patients. We hope California will join the 28 other states that have enacted RDACs to support and help give voice to the rare disease patients and families. Thank you.
Thank you. Any other witnesses in support?
Lynn Kinst, Executive Director of the Hemophilia Council of California, in strong support. Thank you.
I'm Jennifer Canvasser, the founder and executive director of the Necrotizing Enterocolitis Society, and on behalf of my son, Micah, who died from a rare disease, and babies like him, I'm in support.
Hi, I'm Kelly Goss. I'm managing director of advocacy for the ALS Association, which is a member of NORD, and we're in strong support.
Diane Nugent, representing the Hemophilia and Sickle Cell Centers throughout the 13 Western states, especially California. We are in strong support. Thank you.
Thank you. Any witnesses in opposition? Seeing none, I'll bring it back to the committee for any questions. Seeing none, I'll just offer a comment. Oh, Mishavo, go ahead.
I just wanted to say just a lot of respect for the author. I know you've been a champion for your sister, and really appreciate that.
Thank you. Mr. Zuber, I want to thank you, Assemblymember Zuber, for bringing forward this bill. I want to acknowledge that this bill is named for your sister, Jacqueline Marie Zuber, who endured a 3-year battle with ALS, and thankful that something potentially beautiful can come from, I'm sure, that very painful experience. The Rare Disease Advisory Council created by this bill will serve as a resource to state government in making sound policy to serve Californians with rare diseases. I want to thank you for being a champion of this bill. Would you like to close?
I respectfully ask for your vote. Thank you very much.
Thank you so much. We will now move to our special order of business, AB 2200, item number 1. As Assemblymember Kalra is coming up to the presentation table, I want to just remind everyone that we are going to allow 10 minutes each for support and opposition, then an additional 15 minutes for both support and opposition for Me Too testimony. All Me Too testimony or additional testimony will strictly be limited to name, position, and organization if you represent one. We will start the special order of business at 3:10 and end it at 4:10. Assemblymember Kalra, you can begin.
Thank you so much, Madam Chair. I would first like to recognize the thorough committee analysis and accept the proposed amendments, and I really appreciate the hard work and many hours put into this by the committee staff and by you, Madam Chair, as well. Assembly Bill 2200, the California Guaranteed Healthcare for All Act, is the policy framework for a single-payer healthcare system driven by quality of care, not profits, that is efficient, not weighed down by administrative waste, and that builds a thriving healthcare network upon a foundation of equity. The last time this committee passed out a policy bill on single payer, the world was still healing from a global pandemic that exposed serious vulnerabilities and inequities in our current system. It was during this once-in-a-generation moment that many questioned our status quo system, a system that incomprehensibly ties access to healthcare to employment, a system that through costly co-pays and deductibles cruelly forces people to ration the care they need, a system that pays the most among high-income countries for some of the worst health outcomes, a system that allows thousands to die and millions to go bankrupt every year. So where are we now? According to a recent 2023 health survey, nearly 2/3 of Californians are worried about unexpected medical bills and affording out-of-pocket costs. The average cost of family premiums for job-based coverage climbed 7% to nearly $24,000 per year in 2024. Last year, 46% of U.S. adult workers with job-based coverage reported having difficulty affording their health care. That's millions of workers and their families. And over half of workers have a large deductible. What does that mean for practical purposes? That means that they're choosing whether they can afford to actually access the health care they supposedly have or not. Healthcare affordability is a top issue for Californians, and many are unable to afford the high cost of care or fear losing their coverage in an economic downturn. Even with the expansion in Medi-Cal, 2.6 million in California will remain uninsured. As many on this committee know too well, we have some of the worst health disparities, and vulnerable populations face greater risks and less access to safety net programs. Black Californians have the highest rates of infant mortality. People of color in California are 20% more likely to have asthma and 10% more likely to be diabetic. The hospital death rate among racial and ethnic categories is practically 10% higher across the board compared to white Californians. Millions of Californians live in areas with acute shortages of healthcare professionals. More than 1 in 5 Californians live in a primary care shortage area, and more than 1 in 4 live in a mental health care shortage area. We hear about hospital closures on the regular, every day, in rural communities and in urban communities. It's for these reasons and a refusal to accept our status quo that I bring AB 2200 for your consideration. AB 2200 would enact a comprehensive framework of governance, benefits, program standards, and healthcare cost controls for a single-payer healthcare coverage system in California. This system would be called CalCare, and it will be available to all California residents. CalCare is designed to cover all medically necessary and appropriate care as determined by a patient's treating healthcare provider or integrated team and consistent with the patient's best interests. Californians will have access to comprehensive health care coverage, including and not limited to all primary and preventative care, hospital and outpatient services, prescription drugs, dental, vision, audiology, reproductive health services, maternity and newborn care, gender-affirming care, long-term services and supports, mental health and substance abuse treatment, laboratory and diagnostic services, and ambulatory services. At its core, CalCare is a simplified public payment system for quality care to our healthcare providers that will set fair rates based on Medicare, but can be adjusted to attract a certain optimal result or ensure adequate reimbursement for services rendered. Instead of hospitals barely getting by or charging consumers unattainable prices, CalCare would negotiate global budget for institutional providers like hospitals, facilities, and clinics so we can actually fund what should be a public good. Healthcare providers will have the ability to appeal the CalCare board for an alternative rate or make adjustment on their budgets in a transparent manner. Finally, the global operating budgets for hospitals, clinics, and other institutional providers include funding for graduate medical education. We have made amendments to the last version of CalCare. Specifically, we added a public retirement benefits advisory panel, Office of Health Equity, more detail on special project budget towards rural and medically underserved areas, fee-for-time payment models, and emphasis on care coordination and prevention. We're also taking special attention at addressing our healthcare workforce shortage and retention in a number of ways. For example, a main tenet of CalCare's methodology is maintaining an optimal workforce to deliver quality and equitable health care. AB 2200 has provisions to increase payment rates in areas that have provider shortages. The CalCare board will be able to increase payment rates to improve the availability and accessibility of health care, and CalCare includes a special projects budget to be used to increase payment rates to improve the availability and accessibility of healthcare services in rural and medically underserved areas. Up to 1% of the entire budget will be dedicated to programs providing healthcare workforce education, recruitment, and retention. And there will be a CalCare Health Workforce Group that will continue to identify efforts to improve workforce and address issues of attrition. Special projects in CalCare will fund the construction, renovation, or staffing of healthcare facilities in rural or other underserved communities. It will also prioritize those projects that address the health inequities that pervade today. Full equity in our health system will only be achieved through a single-payer system of guaranteed health care for all. The Office of Health Equity, now in CalCare, will support the board through data collection, analysis, and recommendations on issues that include barriers to care and access, equitable distribution of healthcare services, discrimination in healthcare settings, and more. Study after study has shown that a single-payer healthcare system with comprehensive coverage for all would produce massive savings on healthcare costs. As a result, California could provide better healthcare coverage to all and do so for less money than our current system. By simplifying our healthcare system, CalCare would save billions in administrative costs. By directly negotiating prescription drug prices and provider payments on a statewide basis, CalCare would be able to lower prices for drugs and healthcare services, resulting in substantial savings overall, also in the billions. The Governor's Healthy California for All Commission found that under a single-payer model with no copays or other cost sharing and with benefits that include long-term supports and services for all, California would save between $32 and $213 billion over 10 years compared to our current system. Opponents will say California can't afford to sustain this system, but the Commission also found a higher rate of growth in spending to our current system. And under a single-payer system, the gap of funding needed is $16 billion less than what California has already paid for employer contributions, premiums, and out-of-pocket expenses that our status quo requires us to pay. The reality is that CalCare is not only good for California businesses, it is good for California businesses who are being pummeled with year-over-year insurance premium increases with no ability to negotiate or push for some sense of moderation. The Commission conducted polling that found that 65% of Californians with low incomes and 72% of Californians of color with low incomes support a proposal to replace all Medicare, Medi-Cal, Covered California, and private job-based insurance plans with a single statewide government program that would cover health care for all people who live in California, regardless of income. CalCare will save lives. The Commission reported a universal health care system would save an estimated 4,000 lives every year in the state. Inevitably, someone will ask how we will pay for CalCare, especially in today's budget climate. AB 2200 is the policy framework and a policy bill that's needed to engage the federal government on a consolidated waiver, and there would need to be a fiscal analysis on what funding will be needed to fully transition and implement it. This may take years, but we should and must act now and make progress on the policy, or we don't even get to any point of discussing how we can create real cost savings for Californians. Members, we have an opportunity to set the stage for universal, affordable, equitable healthcare justice for all in California and be a model for the nation on what a progressive alternative to our fragmented, profit-driven status quo would look like. Imagine for a moment how California would have fared under a single-payer, universal healthcare system during the COVID-19 pandemic. People that immediately lost their jobs would still have their health care. Hospitals would not need to worry about a pay source. The state would be better coordinated on providing access to vulnerable communities and directing critical health care services like PPE and vaccines. And most importantly, lives would have been saved. One published study examined the potential benefits nationwide and estimated that the United States would have saved 212,000 lives in 2020 alone, and that $106 billion of medical expenses associated with COVID-19 hospitalizations could have been averted. CalCare is not just a healthcare justice bill. It's a racial justice bill. It's an economic justice bill. It's a gender justice bill. It's about affirming the fundamental right to health care, a right that should never, ever be contingent on your job, on your wealth, or where you live, or where you were born. With me to provide supporting testimony is Michelle Gutierrez-Vo, an RN and president of California Nurses Association, Carmen Comste, policy specialist with the California Nurses Association, and Ismael Almendarez, president of the Oakland Educators Association and representative on behalf of the California Teachers Association.
Thank you. And just as a reminder, you will all collectively have 10 minutes.
Just mic drop at that point.
I'm Michelle Gutierrez-Vo. I'm a president of the mighty California Nurses Association, and I've been a registered nurse for over 26 years, representing over 100,000 RNs across the state. CNA is a proud sponsor of AB 2200. As a nurse in an adult family medicine outpatient clinic in Fremont, I witness preventable health care tragedies every single day that result from our profit-driven system of insurance. Patients forgo the medication and care they need simply because they cannot afford it. Meanwhile, health plan middlemen deny care to boost corporate bottom lines. I cannot tell you how many times a day I work 5 days a week in the last 23 years at Kaiser as a charge nurse of the clinic. I cannot tell you how many times a day I have to beg my patients who work 2 to 3 jobs just to pay for health care insurance they have no intentions of using unless they are dying. I would like for you to take a pause and remember that statement, because I don't want to waste today unless we move forward. They are counting on us. As the COVID pandemic ruthlessly demonstrated, high health care costs and poor health outcomes persist because access to an insurance plan is not the same as guaranteed health care for all. Our current profit-driven system is deeply inefficient, unaffordable, and unsustainable for California and our patients. It is designed to squeeze every dollar and cent from our health. As a nurse, I have a professional duty to ensure that my patients receive the therapeutic care they need. This is why union nurses advocate for universal guaranteed health care for all under a single payer system. The legislature must act with urgency to pass CalCare because any delay will be paid through the health and lives of our patients. We must act now. CalCare would establish a single standard of care for all Californians, regardless of income, regardless of employment or immigration status, and regardless of whether an insurance company thinks we are profitable. Everyone gets the same high-quality care. Everybody in, nobody out. Study after study has shown that a single-payer system like CalCare is the only solution that would allow everyone to get the care they need while reducing healthcare spending overall. With CalCare, California would save lives and save tens of billions each year. This savings would go towards providing comprehensive care to all. In other words, CalCare would control costs without resorting to care rationing. Importantly, CalCare would not only save money, but it would improve their lives and practice of nurses like me and doctors like you. We'd spend less time and resources navigating insurance and have more time for our patients, resulting in better care. For our union members, CalCare takes health care off the bargaining table permanently. This gives us more bargaining strength to win better working conditions, safe staffing, and other protections on the shop floor. This is why CalCare has the endorsement of dozens of California unions, which represent over 2.3 million union members across the state. As union nurses, we understand that CalCare is an act of solidarity by placing every person in California into one system. In solidarity with one another, we would come closer to achieving health equity. It is my duty as a nurse to advocate for my patients and end suffering under our tiered system of care. Healthcare must be treated as a human right, not a commodity. We urge you to vote in support of CalCare today so we can begin to heal our broken healthcare system. Thank you so much for your time.
Good afternoon, Chair Bonta and committee members. I'm Carmen Comsi, Lead Regulatory Policy Specialist with the California Nurses Association. Since last session, we've worked diligently to incorporate feedback from legislators and stakeholders, and we want to thank you again for your time today, and I want to touch on some key components. CalCare is ultimately a reinvestment of our healthcare dollars into care instead of ballooning prices, administrative complexity, and corporate profiteering. On savings, the Healthy California for All Commission also found that it would save $40 billion each year on insurance administration alone. And when it comes to receiving care, CalCare eliminates insurance barriers and financial barriers to care. CalCare creates one network of providers spanning the state where care would be free at the point of service. With CalCare, we would get more, pay less, and provide comprehensive benefits and high-quality care to everyone. This framework importantly establishes the policy legislation required under federal law to begin negotiating federal waivers needed to incorporate public programs into CalCare. For provider reimbursements, CalCare aligns payments closer to cost and uses our bulk purchasing power to win fairer prices for everyone. For rural and underserved areas, payment rates would be adjusted upwards to ensure that they have the resources they need to stay open. By stabilizing funding for hospitals and clinics throughout the state, we can finally combat the epidemic of healthcare closures in rural and less affluent areas and for communities of color, which leads us to a really important point of CalCare. It creates the framework to begin dismantling the structural racism and structural health inequities that our current system is built upon. A new Office of Health Equity would identify distributional gaps in our healthcare infrastructure, and it would develop programs to address disparities in rural and medically underserved areas, including programs to meet the cultural and linguistic needs of all patients. Savings from the elimination of insurance administration and profiteering could be used for additional staff, extended office hours, or hospital renovation and construction, and to boost healthcare staffing and other resources. The bill includes provisions on healthcare workforce recruitment and retention. Programs and funding would be available to build a diverse workforce pipeline and to keep nurses and other healthcare workers in good, safe jobs with safe staffing levels while they care for patients. Passing CalCare's policy legislation today is an important first step that California needs to take on the path towards implementing guaranteed health care for all as a right. Thank you.
Good afternoon, Madam Chair and committee. My name is Ishmael Armendariz, and I am speaking on behalf of the California Teachers Association, and I'm a very proud special education teacher and president of the Oakland Education Association, 3,000 members strong. I'm here to talk about how CalCare would improve education in California. I want to just make a couple of points. So we bargain healthcare. This year, we were collectively bargaining with our district and with Kaiser, and Kaiser came with a 25% increase to our healthcare in 1 year. Now imagine this. They came with their slides. The first slide said, 1, you have a lot of women. You employ a lot of women. The second slide said, your birth rates have gone up, which cost money. Then the third slide said, you employ a lot of people of color and they're expensive to employ. Because of this, your rates are going up 25%. That is money that is coming out of our classrooms, money that is intended to retain teachers and to keep teachers in our already systems that's driving us out. So by taking healthcare off the bargaining table, that would allow us to invest into our classrooms, to retain teachers because teachers are leaving the classroom. We can invest in teachers. We can invest in services such as counselors, social workers, nurses. But more importantly, it ensures that every single teacher and every single student and every family that comes into our classroom has access to high quality healthcare. And that is why we support this. So I urge you to support the bill, to vote for the bill, and I urge you to stand with California nurses and stand with California teachers, and let's get this done. Thank you.
Thank you. We'll now have primary opposition come forward.
The ops are rolling up.
You'll collectively have 10 minutes.
Thank you, Madam Chair and members. Nick Luizos with the California Association of Health Plans. CAP represents 40-plus state-licensed health plans in the state of California, delivering high-quality and coordinated care to approximately 27 million Californians. Our members operate in all markets, individual, employer, and public programs like Medi-Cal. CAP also supported the Managed Care Organization tax last year, which is a tax on our members and our consumers, more specifically your constituents, to invest more money in the Medi-Cal program to improve rates for providers and improve the delivery system. CAP is part of a coalition that is strongly opposed to AB 2200. Our coalition consists of doctors, hospitals, employers, and others that are strongly opposed to this bill because it is too costly, eliminates choice, thrashes our existing delivery system, and ignores the hard work that we have done in California and the hard work that we are still doing. Overall, members, it makes 0 sense to replace our current healthcare system with a costly, untested new system that would hurt patient care, especially when we're making strides on affordability and are so close to achieving universal coverage in the state of California. Thanks to actions by this governor and the state legislature, California is closer than ever to achieving universal health care for all. Since Covered California's first open enrollment period in 2013, Californians' uninsured rate has fallen from 17.2% to just 6.5%. Nearly 1.8 million people enrolled in Covered California plans during the most recent open enrollment period. That is a record number of health insurance signups in the state. With new policies beginning in 2024, virtually all Californians will have access to health coverage. And we continue to make strides in making healthcare more affordable for low and middle income Californians. New subsidies provided under the American Rescue Plan have significantly improved access to affordable healthcare for all. Covered California is also in the process of implementing cost-sharing reduction subsidies for people at Covered California. Currently, 2/3 of Covered California's customers are eligible for comprehensive coverage at a cost of less than $10 per month. Additionally, the Office of Healthcare Affordability is on the verge of setting a statewide spending target in healthcare that will encompass virtually all sectors. CAP supports a workable multi-year spending target as well as the overall mission of the Office of Healthcare Affordability. Members, one thing that you hear from the supporters of this bill is that Californians are opposed to or believe that we should completely change over our existing healthcare system. And we have found that Californians are satisfied with their health care that they receive for themselves and their families today, and actually want to build on the progress that we've made under the Affordable Care Act and not start over with a new health care system. And yet today we're considering a massive, costly, and untested system that would destroy the progress that we've made thus far. A recent LAO, Legislative Analyst's Office analysis of this bill, or single payer, I should say, not the specific bill, single payer legislation in the past pegged the annual cost of single payer at roughly $500 billion annually. That is more than twice the typical state budget. And we don't have a funding plan associated with this bill, and we'll hear more about that later. Almost half of the funding, roughly $200 billion annually, would require a waiver from the federal government in the form of congressional action. Even if granted, this could be revoked by a later Congress, leaving California's single-payer system, if it is enacted, with a massive budgetary shortfall. The other half of the funding, around $250 billion, would be paid for by taxpayers in the form of higher taxes on jobs, income services, and more. If the congressional waiver does not happen or gets revoked, the taxes would need to be doubled, roughly. Californians, by and large, oppose the tax increases that would be necessary for a single-payer system. And access to quality health care if one of the other things, that you hear from the supporters of this bill is that other countries have enacted some sort of single payer paradise in other countries. But if you really look at the evidence, access to quality healthcare has suffered tremendously in other single-payer systems. According to some studies, the median wait time in Canada, a country with a single-payer system, between a referral for a general practitioner to a specialist procedure is 27.7 weeks. That's in contrast to the wait time in the United States, which is under 30 days, about 26 days. Also, Britain's National Healthcare Service is in crisis as it deals with the lack of facilities and equipment, cost increases, and an exodus of healthcare providers in that system. Indeed, some providers that are just starting
why
out
those
in the
things are
British
falling
healthcare system
apart.
are paid less than baristas and fast food workers in that country. And so I don't know how you would be able to sustain a workforce necessary to keep the system going. Members, as you know, California is facing a massive budget deficit. Our priority should be safeguarding the existing programs and services that we have in place now, not passing legislation for a $500 billion healthcare system that has never been tested. Single payer would force all 39 million Californians out of their existing coverage, including Medicare, employer-based coverage and covered California plans into an untested system with no ability to opt out. Californians oppose single payer that offers no ability to opt out or to choose private coverage. They oppose a single payer system that eliminates Medicare as an option for seniors. Californians want the right to choose private coverage. Instead, single payer will eliminate patients' choice of coverage and could endanger their choice of physicians, hospitals, and other providers. California would lose doctors to other states, leading to longer wait times and reduced access to care. And then members, I'll close with this. SB 770 was legislation that was passed last year, and that is initiating a process to explore the necessary federal waivers for a single-payer system. Passing full legislation is not only premature but highly questionable at this time for this and for budgetary reasons. And until whether we know a waiver is even possible for the state of California, we shouldn't be considering this bill. So, I think that's a good place for me to stop, and I'll pass it over to Preston from Cal Chamber. Thank you. We're opposed to this bill, and we urge you to vote no.
All right, thank you, Madam Chair and members. Preston Young from the California Chamber of Commerce here today in opposition to AB 2200. First, I just want to make it abundantly clear, we completely agree that every Californian is entitled to receive affordable and accessible health care. However, affordable health care coverage is different than a government-run bureaucracy propped up by monumental tax increases. If we're going to talk about single payer, then we also have to talk about how it's going to be funded. Unfortunately, AB 2200 doesn't do that. Everyone can agree the proposals contained within this bill will require taxing Californians hundreds of billions of dollars every single year. This is completely contrary to affordable health care. This unsustainable tax burden falls directly on the shoulders of California's employers, which is why we're here today in opposition. First, let's talk about costs. A piece of legislation of this magnitude
He looks like a generic
funding mechanism.
business villain.
However, we don't have the benefit of seeing such a proposal today, so we're left to guess at how this will be paid for. It's indisputable AB 2200 will increase taxes for California's employers and employees by hundreds of billions of dollars every single year. The Healthy California for All Commission indicated that California's total health expenditures in 2022 were $517 billion. That's about 1/7 of our gross state product. According to the Office of Healthcare Affordability, California's per capita healthcare spending in 2020 was $10,299. Even assuming federal funding stays in place, AB 2200 would require a significant tax contribution per each Californian to even partially approach these figures. That needs to be kept in context. California already has the highest gas tax rate in the country, the highest sales tax rate in the country, the highest personal income tax rate in the country, the 8th highest corporate tax rate in the country, and I think we can all agree that we have a housing affordability crisis. Now, AB 2200's implementation would require layering the biggest tax increases in state history, not once, but year after year, onto struggling Californians so the state can reinvent and take over one of the most complex systems that exists in our society. Also, the last iteration of this bill included a proposed payroll tax, which I assume will be on the table again. This is worth mentioning since our state's unemployment insurance fund is insolvent and increased payroll taxes are already being assessed on our state's employers. Furthermore, if the bill were implemented, the tax increases wouldn't be static. They would have to annually grow with healthcare costs year after year, meaning the enormous tax increases would have an unremitted pace of growth. Vermont enacted a single-payer bill in 2011, but that was derailed when the state realized it risked economic shock if they instituted the 11.5% payroll tax that they planned, along with personal income tax rate increase. Vermont's governor at the time, Governor Shumlin, stated, and I quote, "What I learned the hard way is it isn't just about reforming the broken payment system. Public financing will not work until you get costs under control." Also worth mentioning, single-payer health care would cost nearly double our state budget. This idea can't be paid for in surplus years. Now we're having this conversation when the state's facing a $38 to $73 billion deficit. Next, we oppose AB 2200 because it will drive employment elsewhere. AB 2200 will eradicate freedom of choice for consumers while heavily taxing employers who expand in California. Since this would be a state system and not nationalized healthcare, employers and employees would be free to leave so they could choose their own private healthcare rather than being forced to participate in a state bureaucracy. They'll leave to avoid the highest taxes in the country, and employers will leave to avoid enormous gross receipts taxes and payroll taxes while being able to expand elsewhere. This exodus will punish remaining Californians with higher taxes in order to offset the funding shortfall. Last, California is approaching near universal health care coverage, rendering AB 2200 unnecessary.
Please wrap up your comments.
Yes, thank you so much. We oppose AB 2200 for these reasons. We ask for a no vote today.
Thank you. I'm going to bring it back to the committee for questions or comments. I'm going to bring it back to the committee for questions or comments to be able to allow some members to be able to offer insight. Assemblymember Schiavo.
Thank you, and my apologies. I presenting 6 bills today. I got to go chair a committee shortly, but I did want to ask some questions and make some comments. And I have some questions for the sponsor, but first I wanted to ask opposition. If you could just clarify, you were talking about the $500 billion. What is that out of the study that was commissioned by the Healthy California for All Commission by UC Berkeley Labor Center?
That was the Legislative Analyst's Office analysis of the prior single-payer bill.
Right. So I think where that number is coming from, and I just hope that we can clarify that here, is actually stating what the cost of healthcare will be over 10 years if we do nothing. That's the current cost of healthcare. So that is not necessarily the cost of implementing a single-payer bill. That is the cost that we are already going to be paying for healthcare, and that study was based on from 2020 to 2030. So that 10-year, we're kind of in the middle of it, and maybe an update would be a good idea. But I think that they were referencing it. So, that same study said that we would actually save $152 billion over that 10-year period. Nearly every study that has looked at single payer has said that we will save money. It's not really debated at this point. It will save money. It will cover everyone. Those are the basic tenets of single payer. And we know that, and we see that happen in other countries. And while you quote, wait times in other countries, which I would dispute, we have wait times here. And as someone with decent health insurance, I have had to wait months when my insurance calls me and says I need to come in. They don't even have an appointment for me, and they're telling me I need to go in. And we have people who can't afford to use their insurance, and they're waiting until they die. We are the only country where people go bankrupt, and it is the number one reason for bankruptcy is medical bankruptcy every year, year after year, since I can remember working on this issue, which has been over 15 years. So we don't have that in other countries. And I understand concerns around the budget right now. I would have really loved for this to pass when it was 1,400 and when we had a budget surplus of billions of dollars, been able to set aside money to really start this program, because hopefully we would see the fruition of those savings coming in years going forward that we actually really need right now. But, to say that that we want to continue to tweak around the edges, I think is short-sighted. And anyone that I talk to in healthcare sees a fiscal cliff ahead of us that we cannot afford. Our healthcare system is unaffordable. And we know that that we have to make a change. This is the only one that saves money and covers everyone, prevents death and prevents bankruptcy. And if people want to go figure out how much they could save, there's a convenient calculator on Healthy California website, the Healthy California Coalition website, that actually can help people calculate those dollars. when it comes to business, I would, there's a phenomenal documentary called Fix It, and it's a series. And the first one really focuses on what businesses would save. I'm a small business owner. I come from a family of small business owners. My parents in their small business would pay for health insurance for my dad's one employee before they paid for it for our family. We know that covering the cost of health insurance for businesses, especially small businesses, is crushing. It is crushing them. And so when you look at this issue for businesses, I think that this is actually a huge benefit for them. And something that they are desperately looking for change and improvement on. And it's one of the reasons that we have huge businesses like Amazon trying to create their own healthcare system, because they are so frustrated with the high cost of healthcare, right? I do have some questions that I want to ask the sponsors and better understand some of the thinking on the bill as well. And I know that AB 2200 directs the state administration to apply for federal waivers, and it does not in any way constrain what the governor negotiates with the federal government. And as a result of those negotiations will be applied by a CalCare governing board who will have complete authority to design and implement the program. I know in the last iteration in 1400, the program would come back to the legislature at a point. It looks like that's taken out in this iteration of the bill, and I just wanted to better understand the lower involvement from the legislature and what the thinking is there.
Thank you, Assemblymember Chavo, and we really appreciate your ongoing life's work on single payer. I think one of the points on the question of federal waivers, because this bill is focusing on a policy bill, and we've taken the ACA with the financing and put that aside for now. We really wanted to focus on the policy legislation, so that there wasn't any confusion about the legislature acting on a financing plan, because the plan is to be able to speak to that in the years to come after we get the policy legislation moving forward. And just, so that everyone is clear with the federal waivers, Congress doesn't have anything to do with federal waivers. It is a process that has been outlined in the Affordable Care Act with the U.S. Department of Health and Human Services, and they have very strict regulations that include a requirement that a bill has to be passed, a policy legislation has to be passed before it can actually start to consider a federal waiver. On a number of points that Assemblymember Chavo pointed out, I just wanted to clarify that the savings that the Healthy California for All Commission found, that it was very specific. It's the closest study that we have on the bill that we have before us today on AB 2200, where it includes no copays, long-term care for all. And the range just depends on how much the UC Berkeley Labor Center had estimated in terms of the increase in inflation generally. So depending on how much inflation happens, we'll save either between $30 billion to $200 billion plus. So, yeah.
And I just want to mention, the legislative authority. So that amendment, or that text you're referring to, was an amendment that was taken the last iteration when there was a separate ACA. Legislative authority will certainly be attached, particularly the financing component of it, when it does get to that at some later stage. But that being said, there is definitely a fine balance of making sure that the CalCare board's powered versus having to come back to the legislature for too much and encumbering the daily operations of CalCare being effective. But definitely open to more suggestions and thoughts on it, and we can give you more background on why that was done back when on the earlier iteration in context of the ACA, and more than happy to get back to you on that.
Thank you. Yeah, I would love to work more closely. I haven't had an opportunity to do that, as I have not had an opportunity to be a co-author. So, hopefully that can change. But I have to go chair a committee in 10 minutes, and I know other people have questions. I just want to, just one more comment. As someone who worked at CNA for 13 years, I see friends here who I've been in the trenches with on this issue and have deep, incredible respect for the work and holding the line on this issue and moving it forward for decades. And also the staff who have worked really hard for many years. I've been there. I've been up. I have a picture of me with my daughter sleeping on the sofa while I was working on getting ready for a previous iteration of this bill until 2 in the morning on a regular basis. And so I know how much work is going into this. And at the same time, you know, it's been decades, and it's kind of the same approach. And I hope that this will get across the finish line this time. But if it doesn't, I really hope that there is an honest reflection on whether or not this is the right strategy. I think that there really needs to be an honest discussion around the approach that is happening right now. I have, you know, serious concerns. We've had many years to bring together people to find resolution to big issues like the GAN limit and Prop 98. I have not heard about progress that's happening there. I hope there is, and, you know, happy for you to answer that, but I'll have to leave and I'll watch it later. I see a lot of division in the movement, and I don't think we can win divided. And I think that you know, it's a big, complicated issue, and you need a lot of people at the table in a real way to be able to push this over the top. That's how we see big policy happen in Sacramento. And I don't see that. And so I will be supporting it today, as I have, you know, supported it for many, many years. I really, really hope that those things change. I really do. I think that I'll leave it at that. Thank you very much.
Thank you, Assemblymember Schiavo. We are going to just make sure that we are ensuring that we have a robust conversation, and also balancing the fact that we have still a very long remainder of the agenda. We are going to go with Dr. Weber, and then Mr. Jones-Sawyer, and then Mr. Patterson.
Thank you, Chair. And seeing the time, and after talking with your Chair, I will keep my my questions very, very limited, because I do want to give others the opportunity, and I also want to make sure that those who came here have the opportunity to speak. So first, I want to start by thanking the author and the sponsors. I have the utmost respect for the author of this bill, and you know, what you have done once again, or what you all have done once again, is to highlight a significant issue within our healthcare system, not only here in California, but within the United States. Yes, healthcare is a right, but it is not affordable. And there are so many issues, so many obstacles, so many barriers for patients to get the care that they deserve, for providers to be able to provide the care that they should. And, you know, like I've said to many people who have come to talk to me about this, this is, in my opinion, something that should be discussed and passed at a federal level. It should not be something that California is trying to do alone, but it is something that we should have throughout the country. I am a little confused as to what would happen if this bill were to be passed as is, but we don't have time for me to really go into that. So my concerns, this bill has a lot of holes in it. There's a lot of unanswered questions, and this is a very, very important issue. We're talking about the health care for all Californians, current and in the future. I read the bill in its entirety, all 70 plus pages. And so I'm just going to focus on a few concerns. I'm not going to talk about the grant waivers. Other people have talked about it. I've talked about that before. I'm not going to talk about taxes for people. I'm sure other people might talk about that. One of my concerns is the CalCare board. This bill gives this board tremendous authority Now, they will receive state and hopefully federal money. However, it is a, quote, independent entity not affiliated with any agency or department. If you look through the bill, if you read the bill, or even just read the analysis, the things that this particular CalCare board is over, which is the financial structure, the provider institution contracts, building maintenance, employee staffing, creating employment structure, negotiating prices, for not only drugs, but devices, and negotiating provider agreements. I mean, any and everything this board is over. And despite the fact that it's going to be using state funds, federal funds, there's no significant oversight or accountability or a place for the legislature to input in this board, in this bill as is. And I think that might have been one of the things that Assemblymember Schiavo was getting at. You know, one of my concerns is that in the bill, we passed this, right? And the only thing that prohibits it from actually going into effect is it says a bill would prohibit specific provisions from becoming operative until the Secretary of California Health and Human Services give written notice to the Secretary of the Senate and the Chief Clerk of the Assembly that the trust fund has the revenues, and then the California Human Services Agency will be required to publish a copy. That's it. It doesn't say anything about once all of these things are figured out, it's coming back to the legislature so that we know exactly what we would be implementing. There's nothing in here that necessarily states that if CalCare implements a policy, it's got to come back to us. And I think we know of another commission that legislators continuously complain about that has all of this authority to go out here and increase prices, and we have no say, yet we're the ones that represent. So I'm concerned about the significant authority that you've given to the CalCare board with no other input from the legislature. The other thing, I discussed this last week on a bill. By giving providers the ability to essentially decide what they want to do for their patient, putting it in our hands, you discard evidence-based methodology, you discard best practice guidelines, and you essentially decide what practitioners want to do for their patients, right? And that is very scary, because remembering what happened in COVID, just because I have an MD behind my name does not mean that I am practicing evidence-based medicine. And we saw that with providers saying, don't get vaccines, take this weird medicine, right, that nobody says is correct, but I'm the provider and I think that's what's best. It also allows for continued discrimination within our healthcare system, because I, as a provider, can choose to give you a certain medication or choose to treat you a certain way, but another patient that walks through my door who looks different, who may come from a different background, a different gender, whatever, I can impose my biases in my decision. Where now, when you have standards, practice, your standards of how we practice, evidence-based approach. If you start to veer, there are checkpoints, right? And it may even be the insurance companies at time that say, we're not going to cover this medication. It's also expensive, because when you eliminate that step therapy, that says I can choose to, as a surgeon, you come in with pelvic pain, I don't necessarily have to work you up. I can just go straight to a diagnostic laparoscopy. I don't have to go through the steps to say, let me try NSAIDs, let me see if hormonal therapy works, let me try, another thing before I take you for the more expensive procedure. So, concerned about that. I've talked about this also many times around this issue. Allowing California to continue to be competitive to get providers to come here. I am concerned with the way in which this bill is structured, that we would create a system where we would no longer be competitive to get providers nor to maintain the providers that we have, especially around specialty care. There's a section in the bill that explicitly states there shall be a presumption that Medicare fee-for-services for reimbursement constitute reasonable fee-for-service, which is interesting when just in February of this year, the AMA published a an article that says, quote, what doctors wish patients knew about the Medicare physician payment system. And it highlighted the fact that Medicare rates have not kept up with inflation. And actually, when you adjust for inflation, Medicare physician pay over the last 23 years has been cut by 30%. So we are coming out of the box going to provide our providers less money and think that they're going to come or stay in practice here in California. We already have a provider shortage. And if we don't do this correctly, we'll just worsen that. We are also removing, individual autonomy, which, if someone, one of the things that jumped out at me is that if a person was eligible for an income-related subsidy, right, and they decided, I don't want it. I don't want to apply for this. In the bill, they have to. They have to apply for it, and if they do not, then they will lose their CalCare coverage, right? If they haven't applied or provided the information within 60 days, it's gone. And so I'm very concerned about some of the things, the way in which that are actually in the bill, not the concept. We have got to fix our healthcare system. But the things that are currently in the bill are very, very concerning. And the fact that if this passes as written, it doesn't come back to us at all. All of these things are done. All of these things are implemented. Let's say the money gets there. A letter is just sent stating the money is there. CalCare is off and running. And so, I think that there's a lot more work to be done. Definitely appreciate your persistence with this and the sponsors' persistence with this. But I think that this is so important that if we're able to do it, we need to do it in a manner that will actually help Californians and not ultimately end up harming them. So thank you.
If I might, Madam Chair.
I'm actually
Okay.
going to I'm going to establish quorum right now. My apologies. Secretary, please call the roll.
Bonta?
Here.
Bonta present. Waldron? Waldron present. Agar Curry? Agar Curry present. Arambula? Arambula present.
At least they're persistent about all their concerns every single time these bills get heard. Nothing new.
Joe Patterson present. Rodriguez? Sanchez? Santiago? Chavo? Weber? Weber present.
We will continue with committee members' questions and comments. I'll move to Assemblymember Jones Sawyer and then go back to you before Mr. Patterson asks his question.
Okay, and then maybe I can move this along by asking Mr. Kalra to answer these three questions, maybe in your summary or immediately after, and maybe we can bring this down to a level that people who are listening hopefully can possibly understand from a consumer, just from people who have to use these. As you all know, or you may not know, I'm someone that has lifetime health insurance with the city of Los Angeles. At one time, I had double insurance with both the state of California and the city of Los Angeles. Many of you have seen me hobble around this building and other buildings with a knee problem. A knee problem that I've been working through with Kaiser for the last 6 months. So I don't know where you got your specialist that you can get to people in 29 days. And it wasn't until this pain got to a 10-plus level that I finally have gotten, and this is someone that has health insurance, I finally got somebody to tell me that hopefully within 2 weeks, they can tell me when they can do the surgery. I have health insurance. Let me say this again. I'm supposed to have one of the better health insurance. And every member on this committee, every member in this building, every lobbyist have seen me struggle for over 6 months with this malady. I just hope whatever we're doing will not increase the level of care that is needed for individuals. Because you'll lose me in a minute if that is the case. The reason I'm going to go ahead and move this along and do the motion is that I want to continue this, because right now it's not working for me. And in 2 weeks, when I visit my doctors and they tell me another 6 months, I will lose it. And they will be calling LAPD on my ass. Because I can't take it anymore. So that's one for me. I need to know that, and this is just for anybody out there that's listening, they just need to know whether or not this is going to improve their health quality of care whatever we do, once this is done. Two, many of you know I have a mother who will be turning 88 on Thursday. It's her birthday. We just brought her back from the hospital. For seniors out there, I'm worried about their quality of care. Right now, I pay additional insurance for her so that she doesn't have to lose her home. We don't have to go into debt to pay for her, because she has diabetes, she's on dialysis, she has heart problems, and she's probably in the hospital once a month with some kind of emergency care. And if you think about that, just the dialysis alone could be catastrophic if we had to come out of us with out of pocket. And so for those seniors who have ongoing medical maladies, we need to make sure we take care of them first. Yes, this is a nice esoteric discussion and budgets and big, but at the end of the day, I don't care. We got to take care of them. And the additional money that I pay for Medi-Cal and Medicare comes to like $600 a month. And I have insurance. So I pay another $1,000 a month for me and my mother, so that we can have medical coverage on top of what the city of Los Angeles already puts in. So that's a real concern. And then lastly, when my mother first got sick, I remember getting her credit card bill, and it had close to $12,000 on it. I said, Ma, what the heck is going on? And it was for prescription drugs. It was for about 100 pills. My Lord, at $120 each or more, $1,000. I mean, it was ridiculous, the amount of money. And it wasn't until we were able to get her into Obamacare at that time, that's how long ago it goes, that cost would have been incurred for her for the last 10 years. So prescription drugs and that cost is just as debilitating for people out there, whether you're poor or whether you've worked a long time and you have insurance. If I have to put out a whole lot of money going forward on prescription drugs, that is a non-starter. And so if you can answer those questions, because those are really, I think, important questions to seniors, to people who work every day, and to people who have to have prescription drugs. They need to know that if we move forward with this, that their quality of life will not go down even more so because we make this happen.
Before any response, I heard a motion. Do I have a second? Dr. Arambula, thank you.
And I said you could answer it.
I'll let you respond.
Would you prefer if others go and then I should give one response?
Mr. Patterson, that would be great. Thank you.
Great, thank you. First of all, please, for the love of God, don't make Mr. Jones Sawyer grumpy next week or in a couple weeks. Appreciate the chair for giving me some time here. I do want to take a moment to well, first of all, make everyone a little mad, I think. But, I think a lot of this comes from, the elephant in the room. I mean, I've only been on this committee for a year, but it seems like a daily occurrence, whether it's in this committee or just whether it's with my conversations with doctors or hospitals, or the frustrations essentially getting paid. And I just think it's, for example, just the other day there was opposition on a bill to oppose somebody dying of an overdose, and we're going to try to get back to them in 72 hours in order for the doctor to provide that medicine. I have opposition on my bill today that would simply continue existing coverage of make sure colorectal cancer screenings are covered if some questions are brought in because of some litigation in some other state. So I think we have to get serious as a, really together. I mean, I want to work with everybody to make sure that, when people have health insurance and when the providers are providing that service, that we know that it's going to be paid. Because I mean, it is a constant. I put together a medical advisory group of all sorts of people, and we couldn't even get past agenda item number 1 because it was a lot of frustrations from all my constituents that are in the medical field, and it's something we really have to address. But I do have a lot of concerns about government-run healthcare, and I'm not just saying that out of some, philosophical view, but like right now I'm dealing with, an issue where individuals who actually had private insurance or were on TRICARE that are being forced onto Medi-Cal, and their doctors, there are no doctors that cover their specialty developmental disabilities. And despite lots of work with the department and things like that, I mean, we just can't. I mean, they're losing their coverage right now, despite the fact that they have insurance and they want to stay on their insurance. And I thought that was all going to be solved. Speaking of Obamacare, I thought that was all going to be figured out there. But I actually don't. That is a problem of a government mandated system, and they really just want to keep their private insurance. And so, obviously we've had conversations here about the costs and things like that. Obviously we're going to need some details. I do think the chamber brought up a good point about what businesses, if there's some runway, a couple years, 3 years, before we really know the expenses or what it's going to cost, I think they're going to start thinking like, hey, what's my long-term gain in 3 years from now? Maybe I should leave this state now so I don't have to participate in this expense if they don't know it, if they don't know those questions, the answers to those questions in advance. So, obviously, I mean, it's probably no surprise to you. I'm not going to support this today, but you're always bringing the small item issues before the legislature. So thanks for doing that. And please just don't make Mr. Jones Sawyer mad.
I'm going to have Wendy Carrillo make the last comment from committee, and then we'll give it back over to you for any comments.
Thank you, Madam Chair. And I feel it necessary to also give a disclaimer on behalf of my colleague from South LA who will not get law enforcement involved in his situations moving forward. But I do agree with a lot of his sentiment. I think a lot of us have personal experiences when it comes to lack of quality of health care, lack of insufficient quality health care, over incredibly burdensome cost associated with health care. A lot of folks in my community of Assembly District 52, which includes East Los Angeles, Northeast LA, rely on the emergency room, and that's already incredibly costly. A lot of community clinics are becoming less and less available in our community, less and less doctors and nurses, affordability of healthcare. All of these things are true. And I really just want to bring into the space a gentleman that we lost, Addie Barkin, who has been at the front lines of Medicare for All for many years. And while we may discuss issues related to health care at disproportionate ages, Addie was 39 when we lost him, and we lost him to ALS. and he was a family man, husband, father, and a staunch advocate for healthcare. And we know in this movement so many people that we continue to lose because of just an inability to receive healthcare in time or preventative. I want to thank the author for all of his diligence and hard work and having the meetings necessary at the federal level to get California get the federal waiver to even begin this conversation as to what it would look like. And I think it's important that we recognize all the work that's being done across the state and across the country. I completely, want to say respect the opposition and their point of view, but at some point in all of our lives, regardless of who we work for, or how much money we make, or where we are in life, we will know someone that is impacted by the lack of healthcare coverage or good quality healthcare, and we will know someone that is going to go bankrupt because of their high cost of bills. We know someone that's going to lose their home, lose their livelihood, lose their job, lose everything they have because they are trying to live their life with a disease, an illness, a family member going through cancer. We've heard the stories, and there are millions of them across the country. I want to thank the advocates that are here. Some I know are here from Los Angeles and various other places across California for their continued advocacy. Some constituents of mine who are in the room or are watching back home and couldn't make the trip up here. It takes effort to come up here and have 30 seconds or 10 seconds of testimony and to, really commit any free time that you have to fight for healthcare, and not only fight it for yourself and for your families, but fight it for every person across the state of California, because that's who you're fighting for and that's who the nurses are fighting for. So I'm proud to be a joint author, proud to continue to support the policy in a variety of different ways for the past few years, continue to put pressure on the federal government to really move forward with the promises that were made during campaigns and promises that were made here to the 40 million people that call California home. Nothing is ever perfect. I think the conversations related to healthcare in the state are critical. We know that the state of California is coming with more and more double seniors at the same time. Lack of, again, as I'll mention, lack of professional healthcare personnel to take care of our communities. The more that we work on this, I think gives us in a better space, and more people are supportive of the work that is being done. There's a lot of work to be done, but I think we're headed in the right direction. And while I think policy committees are always hard, it's always harder to present and sit with your opposition and try to come to common ground and try to really tell the stories of everyday people who are suffering and who really want us to do what's right for them. And so I'm happy to be supportive of the bill and continue to move the conversation forward. Thank you.
Thank you, Madam Chair, and I'll try to answer some of the questions very quickly. Appreciate Senator Carrillo for long-standing support and for her comments today. As to Dr. Weber, who made some excellent points. One of the points that she made was she believes it should be passed at a federal level. The ACA waiver process was created so that states could move forward with a variety of programs, including potentially a single-payer program. So it's been set up in a manner for states to take the lead, to be the ones that move forward with it. It's the same way that many other countries, Canada is an example, that started at the state level, and actually each state has their own program that the federal government helps to fund. And so that's the reason why we lead as a state on the policy. One of the questions she raised, also a good one in terms of giving doctors, nurses the autonomy to make that decision, the decisions in the operating room or in the hospital room. Really, the reason why that's in there is that we don't want algorithms to override the best judgments of those that are actually caring for our patients. Now, can we tighten up the language? Because we definitely want it evidence-based, and I'm more than happy to work with Dr. Weber to ensure that language makes it very clear that we still want to make sure that they're using best practices, evidence-based practices. What we don't want to have is some algorithm or what we see nowadays, an insurance company telling a doctor that they can't do what they see as medically fit. In terms of the CalCare board having too much power, look, this bill is the policy bill. And I want to make that very clear. This is the policy bill on how the actual operation of CalCare would function. And as was mentioned earlier, there are many other steps that have to be in place, including the funding of a system that the legislature would have to approve and give authority to and release those funds to the board. So there's plenty of opportunity, and our intention is to have legislative authority through that process. What we don't want to have, and this is that balancing act, is to have every year you have to go back to the legislature to change something, do this and the other. We need the board, the CalCare board, to be able to operate independently because it is a system that's going to require that level of attention, but it does not remove legislative authority or the relationship between the legislature and the CalCare board, but more than happy to look at language that would better satisfy some of our colleagues if they think there needs to be more language in the policy bill that makes that very clear, that the legislature is not completely cut out of the operation of CalCare board in terms of especially the financing aspect of it. To Senator Patterson, I appreciate his comments. The reality is that when we talk about businesses are being fleeced right now. They're being completely fleeced, and they have very little control over how much they're being charged or how much their rates are going up year over year. If we can relieve them of that obligation, if we can relieve them of that and have them have something that's a fraction of that, which is what would happen under a single payer program, we would actually make it more competitive for businesses to be in California, especially knowing that now they can get rid of all their administrative costs of having to worry about their employees' health care, which is an enormous cost on businesses. And let's keep in mind that Californians right now, including California businesses, are paying the highest healthcare taxes in the world. They're just not called taxes. They're called premiums, and they're called co-pays. They're called administrative costs. So we can play the game of, you're going to be taxed this and other. Let's be real. We have the most expensive system in the world, and we do not have the best outcomes. To Assemblymember Reginald Jones Sawyer's points of these wait times, and let me tell you this. My father's right there in the front row. I take care of him. He's on Medicare. I take him to his appointments. I know how long it takes to get an appointment. I know how much he pays out of pocket. I know he has to have Medicare Advantage, which was, again, a privatization of our Medicare system. And we're lucky that he can afford to do that. If he can't afford to do it, guess how long his wait time is going to be? Forever. And so I really appreciate the comments from Assemblymember Jones Sawyer. Absolutely, the goal is to make sure everyone has access to high-quality care, and the reality is we can do better than Medicare. We can provide long-term care. We can provide vision and dental. My dad has to spend $6,000 for hearing aids. He has to pay thousands for dental work. That's a reality of what people are going through, and you're lucky if you're the ones that can afford it. Those are my answers to those questions.
Thank you. We are going to now move to Me Too's, just as a reminder, because we are over the time that we allotted for this special order of business. We are going to cap Me Too's at 15 minutes. And if you are in support or opposition, you should be lining up now. Wherever we get after 15 minutes is where we are going to stop. The secretary is going to start the clock. Thank you.
Thank you. Brian Ha with the California Faculty Association. We stand in strong solidarity with the nurses, and we applaud the author for carrying this very important bill. Thank you.
Madam Chair and members, Tim Taylor with the National Federation of Independent Business in opposition. Thank you.
Annie Chow with the California Teachers Association in support.
In the name of my niece, Alicia Bates, who was killed because of medical apartheid, as a member of Black Lives Matter Los Angeles and Black Lives Matter California, I stand in strong solidarity with the bill, and I thank the Assembly member for bringing the bill forward. It could have saved my...
As a person who has fought for single payer for over 35 years, with Black Lives Matter's grassroots and the Fannie Lou Hamer Institute, we firmly support this bill.
Dylan Elliott on behalf of Shasta County, regretfully opposed.
Ren Hicks, California's disability rights and a disability advocate in strong support.
Dean Teller with the California Manufacturers and Technology Association, respectfully opposed.
Thank you, Madam Chair. Tom Sheehy, representing the California Landscape Contractors Association, in opposition.
My name's Heather Ablog. I've been a nurse for 23 years, 17 of which at Kaiser in Sacramento in the emergency room. I'm absolutely, positively support AB 2200. Thank you.
Nadine Paybrou-Kane, we support the American Federation of, I'm going to screw this up. It's ASME, and I'm nervous, and I'm sorry, but it's Council 57 and the retirees, Chapter 57, and 35,000 members strong. Thank you.
Dan Plancy, math teacher, on behalf of my students who have had their education derailed, and as a member of Berkeley Federation of Teachers, which has passed a resolution in strong support.
Good afternoon, Johan Cardenas with the California Pandemic Health Network, and we support in concept. Thank you.
Tina Rufo, 35-plus year union nurse with California Nurses Association, in strong support.
My name is Melody Mendenhall. I'm an oncology nurse practitioner from Los Angeles. I come out in strong support of this bill.
Honorable Chair and members, Amy Heinscheich representing Unite Here Local 11 and their 32,000 members in strong support. Thank you.
Brittany Clark on behalf of California School Employees Association in strong support.
Madam Chair and members, Rand Martin on behalf of the AIDS Healthcare Foundation, which is also a managed care plan, in strong support. Thank you.
Forrest Harlan, Butte County Healthcare Coalition, in strong support as well.
I am Will Toperoff, 28-year nurse practitioner working in HIV primary care. I'm here in strong support of AB 2200. Thank you.
Good afternoon, Chair and members. Jessica Moran with the California Dental Association, in opposition. Thank you.
Jane Kim, California Director of Working Families Party. This is our top priority, and we are in strong support. Also, former San Francisco supervisor and individual support.
Hi, I'm Jenny Osgood with the Sacramento chapter of the Democratic Socialists of America, and we are in strong support.
Hello, my name is William White. I speak on my own behalf as a working class 26-year-old person. I would rather see the legislature enact a new system with some problems.
Organization, support, or opposition, please.
Support, strong support. Thank you.
Aaliyah Griffin with the American Federation of State, County, Municipal Employees, in support and concept. Thank you.
Good afternoon, Tim Valderrama with the Weideman Group on behalf of Blue Shield of California in opposition.
Angelica Gonzalez on behalf of Kaiser Permanente in opposition.
Cheng Sim Lim, board member, Healthcare for Us, and also representing Asian Pacific Islanders for CalCare, in strong support.
Caroline O'Riordan, founder, Hollywood for CalCare, in strong support.
Jonathan Karoff, I sit on the board of directors of the California Faculty Association. That's not only endorsed it, but urges strong support.
Jennifer Snyder with Capital Advocacy on behalf of the California Life Sciences, in opposition.
Julie Nielsen with the National Union of Healthcare Workers and Healthy California Now, per our letter in support.
Good afternoon, Mark Farouk on behalf of the California Hospital Association, in opposition.
Madam Chair and members, Yvonne Fernandez, California Labor Federation, in support.
Annalie Augustine on behalf of the Family Business Association of California, in opposed. Thank you.
Mitch Steiger with CFT, a union of educators and classified professionals, also in strong support.
I'm Robin Sunbeam from Mendocino County. I represent not only the Democratic Central Committee and the Inland Mendocino Democratic Club, but also the Mendocino Women's Political Coalition, and they are all in strong support.
Kelly Brooks on behalf of the Santa Clara County Board of Supervisors, in support.
Rachel Bagwet, ACLU California Action, in support.
Finley Thompson Morley on behalf of the City of Sacramento, in support.
Sandra Poole on behalf of Western Center on Law and Poverty in support.
Savannah Jorgensen on behalf of the Lutheran Office of Public Policy California in strong support.
Simon Hyatt, Working Families Party of California Central Valley Chapter in strong support.
Anne Marie Garcia, a Medi-Cal recipient who had to become poor to be one, but it's through Kaiser. And I feel they've been,
Ma'am,
I'm sorry, I'm just lucky, that's all. It makes me sad that I had to be poor to get better health care than I got before from work. We have to start somewhere. I want this to go.
Peggy Elwell on behalf of the South Bay Progressive Alliance in enthusiastic support.
Katie Van Dynes with Health Access California in support. Thank you.
Good afternoon. Alex Kahn on behalf of UCAN, a regional coalition of chambers of commerce, and the California Builders Alliance in respectful opposition.
Catherine Gale, principal at Catherine Gale Consulting, small business support.
Nelson Tam, delegate at the California Democratic Party and officer of the Children's Caucus in strong support.
Good afternoon. Jesse Gonzalez, California Working Families Party, San Francisco, in strong support.
Good afternoon. Matt Aiken with the Association of California Life and Health Insurance Companies in opposition.
Good afternoon. Sherry McHugh representing the California Correctional Peace Officers Association, Benefit Trust Fund, and NAFA California in respectful opposition. Thank you.
Madam Chair and members, John Norwood on behalf of the Independent Insurance Agents Association. Thank you. In opposition.
Patricia Johnson, I'm a RN, former CNA member. I'm on the board of Wellstone Progressive Democrats of Sacramento. Strong support.
Hi, Robert Copeland, DSA Sacramento member, and California Alliance of Retired Americans member. Strong support.
Karen Gale, retired Sacramentan, strong support.
Christopher Sanchez representing the Consumer Federation of California in support.
My name is Case Fritz, co-chair of the Sacramento Democratic Socialists of America, and we voted to support this bill.
Megan Shumway, retired obstetric and public health nurse and retired CHTP deputy director in strong support.
Derek Grasty, board president, Mount Pleasant Elementary School District, representing myself in strong support.
Susan Tapadisto, president of the American River Democrats. We strongly support AB 2200.
Sally Gwen Satterley, an RN for many years. Darn it, I was going to do this. Yeah, very strong support for the California Nurse Association and Santa Cruz for Bernie of 2,000 people I'm representing in Santa Cruz for Bernie, and then, of course, all the nurses. Thank you.
Seth Reed with Reed Government Relations, representing Military Officers Association of America, California Council of Chapters. Opposed.
SEIU 2015, strong support.
My name is Salaya Copeland, SEIU Local 2015, strong support.
Brandon Marchi with the California Medical Association in opposition.
My name is Dr. Flojean Kofer. I am the Senior Director of Policy with Public Health Advocates, and we are in strong support. Thank you.
Julian Canetti, California Hispanic Chambers of Commerce, respectfully in opposition.
Thomas Cronin, local resident, in strong support of AB 2200. Thank you.
Martha Kuhl, RN for over 40 years, pediatric oncology nurse at Children's Hospital Oakland. Strong support, California Nurses Association.
Shirley Toy, nurse for over 44 years, CNA member, strong support.
Ate Esteves, California Nurses Association, a mighty, mighty nurse in full support.
Joe Donahue, registered nurse since late 1970s, so that's 40-some years. Still a member of California Nurses Association, Progressive Democrats of America, Monterey Area Chapter. Strong support, please.
Greg Miller, I'm a retired RN and worked as a hospital staff nurse for 35 years. Strong support, and also a member of the Santa Clara County Single Payer Health Care Commission, which also is strongly support.
Faith Borges on behalf of California agents and health insurance professionals in opposition.
Hi, Connie Chu with California Working Families Party Bay Area, and I support.
Anna Carpolo, SEIU 2015, longtime IHSS home care worker and chair of the Alameda County Public Authority for In-Home Support Service. Strongly support this bill. Thank you.
Thank you, Madam Chair. Jackie Anas on behalf of America's Health Insurance Plans and Elevance Health, respectfully opposed. Also asked to register opposition on behalf of Cigna. Thank you.
I will bring it back for comment before I allow a brief close from Assemblymember Kalra. I want to thank you, Assemblymember Kalra, for your continued commitment to making sure that every Californian has affordable, quality health care, and for your commitment to continue to work on this bill and this framework. Each time this proposal comes forward to the legislature, we get incrementally closer to achieving health care as a right that all Californians deserve. This bill seeks to address what is wrong with our current system, a healthcare system that is expensive and unequal depending upon insurance type. We've made enormous strides since the implementation of the ACA, where the uninsured rate has fallen and consumer protections have made healthcare more accessible. Still, barriers exist in healthcare delays and increased premiums and out-of-pocket costs. And in fact, we sit here as a health committee week after week hearing legislation that attempts to try to fix this Frankenstein of a system. In this agenda alone, we are seeking to make sure that we have coverage for menopause, that we have newborn screening programs available to everyone, that we can ensure that our clinics are adequately covered in supporting controlled substances, that our distressed hospitals are not closed when they need to with St. Rose Hospital, that we ensure we have financial solvency for our different boards, that we ensure that we have awareness around abortion services in the way that we need to, and we go on and on and on. Human milk, with aspects of our healthcare system that continue to not serve every Californian. I know that you have been in this struggle for a very long time, and I want to thank each and every advocate who took time to come here to the state of California and in this hearing room to contribute your voice to what we need to ensure moves forward. We know that this is just a framework that you are starting with, and we know that you purposely separated the framework from and the policy discussion from how we would fund that. And I think that was a smart way for us to go because it provides an opportunity for us to take a real hard look at some of the policy components. And I think you heard from committee members some aspects of this policy framework that still need significant work for us to be able to move forward. And I know that you will take heed with those aspects and continue to work on those should this bill be able to move forward. I support this bill today. I supported Assembly Bill 1400. I respectfully ask to be a co-author at this time on this bill. And I know that you will continue, as I do, to support every Californian in this conversation to ensure that we have adequate health care for everybody that is affordable. I want to thank you for your work and know that we will continue with all proponents and stakeholders throughout our healthcare system to move towards a better California with this legislation. So with that, I we were optimistic in our count. We did not actually have quorum. With 8, we need 9, so we are going to establish quorum and refer back and vote on this bill. But I will give you just a short 2-minute close.
Well, thank you so much, Madam Chair, for your longtime support of health justice and for being so gracious and giving me credit when there's folks behind me that have been in this fight way longer than I have. And I would simply say that I'm so grateful to my colleagues, to those on the Health Committee. I know many of you have been fighting in so many different ways to increase access. But the reality is we know our system is broken. It's unsustainable. And the reality is that with the most expensive system in the world, we have to ask the question, who's paying for it now and how are they paying for it? We're paying for it out of our paychecks. We're paying for it out of gathering all of our life savings. We're paying for it by making choices over food versus medication versus housing. We're paying for it with lives lost in the streets. We're paying for it with the highest number of those entering into homelessness being seniors because they get into a medical emergency and they lose their home because they can't pay their debts. The reality is that we know there's a better way. We know there's a better way because not only do other places do it, but every legitimate study has shown that we have the most convoluted, expensive, and unjust and immoral system that you could possibly create. We can do better, and the reality is that we know a state is going to lead and be the first one to do this. It must be California. California is the one that can do it because we have a large enough GDP, we can make it happen. And ultimately, it's not going to be easy. I do really appreciate the feedback, especially on the policy components of this. Dr. Weber, Assemblymember Schiavo, we're going to take all that into account and keep moving it forward. But the reality is that it does seem like we keep on repeating ourselves by bringing this bill forward and forward. But the reality is also that we're not going to stop. And Nelson Mandela once said it always seems impossible until it's done. And the reality is that we together cannot stop because people are dying. And we know that every single year we have a system that is profiting the very few while the masses suffer. And so I urge support of this bill when there's a motion for it. I'm so grateful to the chair. I'm so grateful to the co-authors, our sponsors, and everyone here in support and everyone around the state in support. I'd be so grateful for your aye vote.
Thank you. That concludes our special order of business right now, and thank you so much, Assemblymember Kalra, for presenting AB 2200. We will move on now to Mr. Wallace. Item number 23, AB 2789.
I guess they didn't have quorum. And now we have to wait even longer. I have to look up the agenda now, see how much more they have.
Good afternoon, Madam Chair and members. I have an equally controversial bill. I'm here today to present Assembly Bill 2789. This bill will create a one-stop shop website to guide new married individuals on how to change their name. Our state was the birthplace of technological innovation, and we don't currently have an easy-to-follow free online resource to help people change their last names. As a result of this deficit, many individuals are purchasing name change kits that can cost upwards of $100. With the cost of living going up, I believe it's important that we provide a free government resource to solve this issue, especially when we have an interest in keeping data accurate for our government agencies. The state courts currently have an online how-to guide, which isn't comprehensive. Under my bill, the website will include a list of all agencies that must be notified, including federal agencies such as the Social Security Administration, the Department of State, the California state agencies, including the Department of Motor Vehicles, the Department of Public Health, and licensing agencies such as the State Bar and Department of Consumer Affairs. Government should make life easier, not more convoluted, and changing a name after marriage should be simple, not a burden. AB 2789 will simplify the name change process by providing transparent information that is easily accessible in one place.
Thanks so much. Are there any other witnesses in support? Any in opposition? Bring it back to the committee for comments. Seeing none, Mr. Wallace, I want to thank you for bringing forward this bill. I know that our committee has been working with you and know that there are ways that we can certainly strengthen an opportunity for this to happen, and appreciate you bringing forward this bill. We will vote on it as we can. Please feel free to close.
Thank you, Madam Chair, and thank you to the committee staff for working with us on this bill. Just respectfully ask for an aye vote when the opportunity comes.
Thank you. We're going to move forward with the authors who are in the room. Moving to item number 2, AB 2064, Jones Sawyer. And I will make a call out to authors who are viewing the screen right now. Please come down. We're trying to move in file order. And would love for committee members to come so that we can establish quorum.
Thank you, Madam Chair. I present AB 2064, which will establish the Community Violence Interdiction Grant Program. This bill is among the 14 priority bills identified by the California Legislative Black Caucus as part of the reparations package. This bill, which would be administered by the California Health and Human Services Agency, will ensure funding for community-driven solutions.
I guess they do not have quorum yet. So I looked on the agenda. It looked like there were about 10 more bills that needed to be heard. Hopefully all of them go through pretty quickly. Then they get quorum, and then they are able to have the vote. I am hoping it's another 15 minutes max at this rate, but shout out to everyone who joined in. Watching, or either watching the recording as it's done on the live stream. If you're hearing this now, you can probably skip ahead a couple of minutes. But fingers crossed, we get through this pretty quickly, and then up next, the bill has to go through Assembly Appropriations, and then to the Assembly floor, where it did not make it out last time as AB 1400. So that needs to happen by mid-May or the third week of May, so the turnaround time is going to be pretty quick once, fingers crossed, this goes through. But now back to your regularly scheduled hearing.
This is, well, I personally know that this is something that you have been working on for a very long time, and that you endeavor to ensure that California has an opportunity to create legitimate pathways for violence intervention through youth development, and really want to support your continued effort in this regard. So with that, when we have the opportunity, we shall vote, but please feel free to close.
Thank you. And one of the unique things about this is that this is based on opportunities that we may have from savings, from closing prisons that are empty, that have no longer they're at the end of their useful life, and so this provides an opportunity to, for the first time, look at savings that we can accrue and then apply those savings to create even more savings by reducing the amount of crime in our communities. So I respectfully ask for your aye vote.
Thank you, Assemblymember. We will move on now to item number 27, AB 2942, Via Purua. Please go ahead whenever you're ready.
Okay. Trying to catch my breath here. Thank you, Madam Chair. I want to start by thanking the chair and committee staff for working with my office on this important bill, and I will be accepting the committee amendments. AB 2942 establishes a pilot program to increase access and diversity in clinical trials for cancer treatment. The American Cancer Society data on breast cancer shows that mortality rate has decreased by only 1% per year from 2012 through 2021. The recommendations for accelerating this progress is by reducing a racial disparity, and AB 2942 does that. Right now, there is no insurance benefit for clinical trials of this nature. Excuse me. This means that only those with access to facilities that offer these trials and the financial resources to pay out of pocket can participate in these trials. AB 2942 specifically creates a program that is would fund clinical trials for at least 80 patients from diverse communities, including women and people of color. This pilot program is specific to the novel allogenic cell-based cancer therapies, which target several types of cancer, including breast, ovarian, thyroid, and prostate cancer. The innovative treatment is non-invasive, and the cost significantly less than chemotherapy and radiation. This treatment is already in clinical trials phase and has proven success in human trials. However, the trials are largely and for more affluent individuals. AB 2942 is the first of its kind because it addresses access issues holistically by providing all wraparound service that accompany care. This includes translation, language service, meal delivery, transportation, and child and elderly care. Increasing access to care is the forefront of California's long-term goal. This, coupled with the innovation that is further through diversity clinical trials, makes AB 2942 essential to advance these goals. With me today is Dr. Karen Abudi, Professor Department of Stem Cell Biology and Regenerative Medicine, City of Hope.
Okay, so this actually might take longer than I thought it was going to. But we will endure. I do not want to go back to being live. If I end this. And let's see. We are double checking the agenda. Not that this is not important, but I don't think this is why people are currently here watching. I actually don't know how many they've actually gone through, so they started at 1:30, so they had an hour and a half before CalCare. And there are a lot. There's like 20 plus bills to be heard in total. I wish they would let us know where we're at, but that would be too efficient.
The journey is profoundly more difficult for patients from low-income backgrounds and minority communities who often face insurmountable barriers in accessing the latest treatments available. Assembly Bill 2942 proposes a practical and compassionate solution by establishing a grant framework to provide access to promising cancer therapies for individuals who might otherwise be excluded from such medical advancements. By doing so, this legislation not only aids in leveling the playing field for health access, but also enriches clinical trials with broader diversity in participant demographics. This diversity is crucial
as it leads to more comprehensive data collection and analysis, helping to ensure that new cancer treatments are effective across a wider range of populations. This bill aligns our moral and professional obligations to ensure that every patient, regardless of status, has access to the most novel treatments available for cancer. Thank you.
Good afternoon, Madam Chair and Assembly members of the Health Committee. My name is Wendy Pizarro, and I'm the Chief Legal and Chief Diversity Officer of Kalidi Biotherapeutics. We are a cancer immunotherapy company innovatively using stem cells to effectively target tumors in our fight to cure cancer, such as glioma or brain cancer, triple-negative breast cancer, melanoma, and head and neck. First, I would like to acknowledge Dr. Karen Abudi, seated next to me. She is our research partner and one of the country's leading physicians specializing in cancer treatments in brain and ovarian cancer from City of Hope in Los Angeles. She is also a mentor to many women in the STEM field. I would also like to thank our bill sponsors of Bill 2942, namely author and Assembly member Carlos Pueda, yes, and co-author Dr. Akila Weber. Together, we are proud to support Assembly Bill 2942, which would expand access and diversity in innovative cancer clinical trials. Kalidi was founded in 2014 and is based in San Diego, California, one of the state's leading hubs for biotech innovation. Consistent with the goals of President Biden's Cancer Moonshot program, one of Kalidi's main goals is to help reduce cancer deaths by 50% by 2043 using affordable, scalable, and universal stem cell delivery platforms to treat multiple indications of cancer, the second leading cause of death in California. We aim to reach all demographics and communities, promoting health equity in biotechnology and healthcare innovation access. AB 2942 is one meaningful and concrete way to achieve this goal.
Thank you.
Thank you.
Any additional witnesses in support? Any opposition? I'll bring it back to the committee. Thank you so much, Mr. Villapurua, for bringing forward this bill. Most of us know someone who has been touched by cancer, and we very much appreciate the opportunity to establish a grant program through this bill that would provide access to innovative therapies and wraparound services. With that, would you like to close?
Just echo what you said, Madam Chair. I mean, it's every one of us knows somebody and someone that's been touched. I mean, and that's going to continue to go. And this bill really is just really trying to put a stop to this. So I respectfully ask for an aye vote.
Thank you so much. When we have an opportunity to vote, we will. Thank you. We'll move on now to Assemblymember Ta, item number 28, AB 3045.
Thank you. Chair and member of the committee, AB 3045 will celebrate contribution of individuals of Asian American and Pacific Islander descent by allowing them to include their Asian zodiac sign when purchasing a decorative birth certificate. According to the U.S. Census, California has a population of over 6 million Asian Americans, accounting for 15% of our state population. Despite being a significant part of California population and playing a key role in California history, Asian culture is often left underrepresented in California. Under current law, the state registrar is authorized to provide decorative heirloom birth certificate with California state seal on them upon request and payment of a fee. These birth certificates are not officially documented, but make as special keepsake. AB 3045 will celebrate Asian culture by authorizing the state registrar to include the Asian zodiac sign corresponding with the applicant day of birth when someone orders a decorative birth certificate. For many Asian American individuals, the Asian zodiac hold deep personal significance, reflecting belief, tradition, and value passed down from generation to generation. If passed, the state registrar would be authorized to collaborate with local artists to obtain the appropriate artwork by Asian zodiac symbol. Anyone would then be able to request the addition of the Asian zodiac sign on this decorative birth certificate and pay a reasonable fee to cover the cost of the artwork as currently authorized under existing statute. This is a meaningful opportunity to celebrate Asian American culture without any cost of the state. I'm honored to present my witness, Dr. Vu Pham. Dr. Pham received his bachelor degree at UCI and his PhD at Asian American Studies at Cornell University. He has been a professor at UCI, UC Davis, and UCLA, and currently serves as the chair of Elevate. As the chair of Elevate, Dr. Pham has consulted for the federal government, university, and Fortune 500 company, Fortune 500 company, while authoring numerous publications regarding Asian American history and leadership. Dr. Pham.
Thank you. Good afternoon.
Please put on your mic.
Oh, there we go. Thank you. Good afternoon, Chairwoman and members of the committee. Again, I'm Dr. Vu Pham, and I have a background in Asian American Studies as well as executive education and business, so you can call me a pracademic. I apply it both ways. And I'm really grateful to be here due to Assemblyman Ta, because, as you know, the heirloom, the little-known heirloom birth certificate program is underutilized and quite unknown by most Californians. And so I'm grateful for the opportunity to advocate for that. And representation matters. We have approximately 6 million Asian Americans here in California, almost a third of all Asians in the US. And as you know, there are probably many of us who subscribe to the Asian zodiac. And that's our birth year. It really determines our spiritual beliefs, our personality, and who we are as people. So in having AB 3045, this would honor our contributions to America, as well as specifically to California, and it would allow us and our allies to really have an heirloom commemorative birth certificate. And finally, I'll give you even economic impact. Basically, Asian Americans, our buying power is 41% higher than the average American, and we, over a lifetime household, will spend about $1 million more than most Americans. So this is a wonderful way to honor us and keep us in America, keep us in California. I plan to be here in California, and I'm very grateful for Assemblyman Ta for the opportunity to really advocate for this.
Thank you. Any other witnesses in support? Any witnesses in opposition? Seeing none, I'll bring it back to committee for comments. Mr. Patterson.
Well, thank you, Assemblymember Ta. You know, sometimes you learn things through this process just by having legislation that brings it forward, and I think it's great. I mean, it's not going to be any expense to the government, and you know, people pay their own fee if they want to be honored and recognize something that's important to the AAPI community. So thanks for bringing this to attention, and looking forward to supporting it when someday we have quorum here.
Really appreciate your comment.
We are so close, Mr. Patterson. Assemblymember Ta, I also want to thank you for bringing forward this, what I think is a very important bill that supports the great diversity of California by creating an Asian zodiac heirloom birth certificate, something that my children and so many others would have benefited from being able to have. And I would love to be a co-author if you would consider allowing me to be so.
Yeah, it's my honor, yes.
Thank you. With that, would you like to close?
I went with it. I really want to thank the chair and committee staff for working with my office, and I respectfully ask for your aye vote.
Thank you. And you shall have that consideration very shortly. Thank you so much.
Thank you.
For committee members, we are now in the phase of hearing only committee member bills. So please get ready to present and come and join us so that we can vote on your wonderful bills. We will move forward with in file order. Assemblymember Haney, AB 2115. I don't know, Haney. You come like just show up and then you get to, I don't know.
I've been presenting bills all day.
We'll get the quorum eventually.
Good timing, I guess. Thank you, Madam Chair and members. AB 2115 will transform California from a state with the most restrictive methadone laws into a state that leads in accessibility for methadone treatment, which will save lives. Methadone is proven to be the most effective treatment for people with opioid addiction. It helps them change their lives and transition to sobriety. It works by easing the debilitating symptoms of opioid withdrawal for people who have quit drugs like heroin and fentanyl. It also reduces the likelihood of dying from an opioid overdose by more than 50%. However, fewer than 1 in 10 people in the U.S. with opioid addiction are currently enrolled in treatment, and thousands are dying each year. During the COVID-19 pandemic, the federal government relaxed many methadone restrictions. These relaxed restrictions led to a higher rate of enrollment and increased patients' access to this medication. In April of 2024, the Biden administration, recognizing that reducing treatment barriers save lives, adopted these rules and made them permanent. However, California continues to have outdated methadone policies that are more restrictive than federal regulations. This is leading to ambiguity for providers and patients, ultimately resulting in less patients having access to methadone. Too many people are dying each year because of these unnecessary laws and bureaucratic hurdles. These intense requirements, like standing in line every day to receive a single dose of methadone, often dissuades patients from pursuing care. They have to spend far too much time getting enrolled and then staying enrolled. That disrupts other aspects of their recovery, like finding a job and stable housing. It often becomes easier for them to self-medicate their symptoms by buying drugs off the street. Additionally, in many areas, the fact that they have to line up every day at these clinics causes them to be preyed on by people who want to sell illegal, deadly drugs. California's laws need to be updated so that patients are able to access medication that can save them, not illicit, deadly drugs like fentanyl that can kill them. AB 2115 will allow them to do that by making sure California methadone regulations are aligned with federal recommendations, providing patients easier access to treatment, removing ambiguity, and preventing unnecessary deaths. With me today in support of the bill is Dr. Christy Soren from the San Francisco Department of Public Health and Dr. Marlene Martin, an associate professor of medicine at UCSF.
Thank you. You'll each have 2 minutes.
Thank you. Good afternoon, Chair Banta and members of the Health Committee. Thank you for the opportunity to testify in support of AB 2115. My name is Christy Soren. I'm the Deputy Medical Director for Substance Use Services for the San Francisco Department of Public Health, a primary care and addiction medicine physician. We are witnessing unprecedented number of people dying from opioid overdose. Thankfully, we have life-saving medication. Methadone treatment reduces the risk of death by 50%. Yet less than a quarter of people with opioid addiction receive this life-saving medication. AB 2115 has the opportunity to change that by aligning California methadone regulations to federal regulations in 2 key ways. First, it updates state regulations that govern methadone clinics. Second, it permits physicians outside of methadone clinics to provide 3 days of medications through a provision known as the 72-hour methadone rule. AB 2115 makes a small yet impactful change to 72-hour methadone by allowing a physician to dispense up to 3 days of medications from a clinic supply while that patient navigates to long-term care. Data supports providing more than 1 day of medication is both safe and improves retention and care. The first few days of treatment are critical when a patient is experiencing severe flu-like symptoms and intense cravings. AB 2115 would allow physicians to start treatment in that critical moment of need and at times when methadone clinics are often not open for referrals. This is pressing for San Francisco, where 2 people on average die a day from opioid overdose. For other counties, it's even more pressing. In San Benito County, the nearest methadone clinic can be over an hour drive away. In Del Norte and Humboldt counties, they have the highest overdose fatality rates in the state and yet only 1 methadone clinic each. These distances can be insurmountable during that critical time of entering treatment. Instead of basing regulations in outdated practices, AB 2115 uplifts methadone treatment to be both patient-centered and rooted in evidence. I have lost patients and loved ones to overdose, and I've seen people struggling with opioid addiction transform their lives with effective medication. We have an opportunity today to increase access to life-saving medications. Thank you for supporting the health of people with opioid addiction and the health of all Californians. I'm happy to answer any questions.
Good afternoon, Chair Bonta and members of the Health Committee. Thank you for the opportunity to speak with you. My name is Marlene Martin, and I am an associate professor at UCSF and director of the addiction care team at San Francisco General. I am here supporting Assembly Bill 2115, which aligns California's outdated methadone practices with what federal standards and research dictate is safe. I am here representing my own views as a doctor and addiction expert on the front lines. AB 2115 will increase the number of people who receive treatment, decrease costs for taxpayers, and most importantly, save lives, because methadone treatment is the most effective treatment for an opioid addiction. Currently, only 1 in 10 people with an opioid addiction receive treatment. Getting methadone treatment today means arriving at 6 a.m., waiting hours for intake, and returning daily to get medicine. These are medicine's so-called liquid handcuffs. AB 2115 would allow people not yet enrolled in methadone to access a bridge prescription while they enroll, increase the amount of methadone a patient can take home between appointments, and expedite entry into treatment. Let me be clear, with an overdose crisis raging in California, we need this legislation. AB 2115 makes fiscal sense. When we make addiction treatment more accessible, we decrease costs and save lives. Let me tell you a story about my patient. He had started methadone in the hospital and was accepted to discharge to a place where he could continue recovering from the assault that brought him to the hospital. With AB 2115, I could have discharged him with a few days of methadone. Instead, he remained hospitalized until Monday at the taxpayer's expense when the methadone clinic would be open for new enrollments. AB 2115 will save lives by making methadone more accessible. Methadone reduces overdose and all-cause mortality by 50%. But most of the people who need it cannot access it right now. No other medication that I prescribe as a doctor has that effect. AB 2115 will increase the number of people on treatment, decrease costs, and save lives. It will bring California up to date with practices that other states have already adopted, and it is much needed in the midst of an overdose epidemic. Thank you for the opportunity to share my testimony.
Thank you. Are there any other witnesses in support?
Vanessa Hina with KP Public Affairs on behalf of the California Pan-Ethnic Health Network here in support.
Good afternoon, Dylan Elliott on behalf of the California State Association of Psychiatrists in support.
Kelly Brooks on behalf of the Boards of Supervisors of Santa Clara and San Diego counties.
Good afternoon, Kelly McMillan on behalf of the County of San Mateo.
Any witnesses in opposition?
Jennifer Alley with the California Association of California Opioid Maintenance Providers, we actually have a concerns position, but we would like to address the committee with your permission.
Please go ahead.
COMP represents California's narcotic treatment programs, commonly referred to as NTPs. COMP's members have been advocating for improving access to high-quality, evidence-based medication-assisted treatment using methadone for over 30 years. And as such, we fully support the intent of this legislation to increase access to treatment for individuals with opioid use disorder. We do, however, have some concerns with the bill. We've submitted language to the author, and we're continuing our conversations with the sponsors. We want to ensure that there's a process for patients to access ongoing opioid use disorder treatment after receiving medication under the 72-hour rule. This is similar to what other states have done. We want to make sure that there's a warm handoff or a bridge to treatment. And we want to have a process in place for the clinic to verify that methadone isn't being accessed from other locations. And we want to make sure that patients are educated regarding the risks of taking methadone. And lastly, we'd like to have a data collection process in place so we can track the outcomes of individuals receiving medications under the 72-hour rule to determine how we can improve access ongoing for all Californians and people in this very bad crisis. Thank you so much.
Thank you. Any other opposition? Seeing none, I'll bring it back to committee for questions or comments. Assemblymember Haney, did you want to address the concerns that were raised?
We're continuing to have the conversation about that. Certainly, we want to make sure that when people do have that handoff and have that bridge dose, that they're able to connect to and continue in treatment. And we were in conversation with your committee staff around that and the best way to do that, and we'll continue to do that as the bill moves forward.
Thank you. And I want to thank you for bringing this bill forward. I know that you've been working very diligently over the course of your time here in the legislature to ensure that we're taking a public health approach to our homelessness crisis and to just a broader approach to intervention and recovery so that everyone can access care. I'm very thankful for that. I look forward to supporting this bill when we have a quorum. Thank you.
Thank you. I'm sorry. It looks like I scared some people away with this one. But I appreciate it, Madam Chair, and I just would say there's a lot that we have to do to confront what is the most deadly epidemic that we're facing in our state. We have to make it a lot harder to access these deadly drugs and a lot easier to get onto treatment. This bill would make huge strides in making the most effective evidence-based treatment more accessible for more people. And with that, it will save many lives in our state and will greatly improve our battle against fentanyl. And when the time comes, would love to have the support of the committee. Thank you.
Thank you. We will, with Mr. Flores' permission, move on to item number 31, AB 3245. Patterson. Please proceed.
Great. Thank you very much. Thank you for allowing me to go right now so I can go to my other committees where I serve as vice chair. Good afternoon, Madam Chair and members. I'll be accepting the committee amendments today. Here to present AB 3245, which requires a health plan contract and insurance policy to provide coverage without cost sharing for a colorectal cancer screening test assigned either grade A or grade B by other accredited or certified guideline agencies, including the American Cancer Society. In short, there's some litigation going on in another state that jeopardized the current process to ensure that this coverage is in place. And so we just want to make sure, obviously, I think it's important to everybody to ensure that colorectal screening continues as is. There should be no additional costs on the plans or anything like that. And recently, when this bill was brought to my attention, I had a friend who had just turned 40 who was diagnosed with colorectal cancer. And fortunately, they did catch it early enough, although he was kind of fighting to get that screening. And they found it at stage 3, and he went through pretty intensive treatment, obviously. And fortunately, 10 years later, he's here with us today, and that's a really great thing. So I understand the importance of this screening, and I want to make sure it continues. And we'll, so that's why when this bill was brought to my attention, I decided to introduce it. And with me, I have Dean Garofalo with California Life Sciences.
Please go ahead, Mr. Garofalo. You have to press the mic.
Thank you. So, member, chair, members, Dean Garofalo with Capital Advocacy on behalf of the California Life Sciences. Pardon me for being a little winded. I was on the other side of the building.
First, see what you did, Flora. See what you did.
We are in support of AB 3245, which would require health plans to cover colorectal cancer screening. California Life Sciences represents over 1,200 entities representing pharmaceutical, biotechnology, medical technology, and academic research institutions throughout California. Following cancer, colorectal cancer is the third most common cancer diagnosed in both men and women each year in the United States. In 2023, over 150,000 adults in the United States were diagnosed with colorectal cancer. These numbers included over 106,000 new cases of colon cancer and over 46,000 new cases of rectal cancer. Over 50,000 deaths from this disease occurred in the United States just last year alone. However, when colorectal cancer is found early, it can often be cured, thankfully. The death rate from this type of cancer in 2020 in the United States was 57% less than what it was in 1970 due to improvements in treatment and increased screening, which detects colorectal changes before they turn cancerous. Through AB 3245, Californians will have increased access to colorectal cancer screenings that can potentially save their lives, or at least catch the cancer early enough to save the cost of the most expensive and arduous late-stage treatments. For these reasons, California Life Sciences strongly supports AB 3245. Thank you.
Thank you. Any other witnesses in support?
Thank you, Dylan Elliott, on behalf of the California Medical Association in support.
Any witnesses in opposition? Seeing none, I will bring it back to the committee. I want to thank you, Assemblymember Patterson, for bringing this bill forward. My father actually died of colorectal cancer because he wasn't screened early enough and had to battle one of the most devastating diseases that we can imagine. So I want to thank you for bringing forward this legislation to ensure that this kind of screening can happen. With that, please close.
Well, really sorry about your father, and thank you for sharing that today. And, obviously this has impacted a lot of people. I know actually several people who have also succumbed to it, and I think the screening is really important. And, the one added benefit to this bill, if anything, is just to get Dean over here and as fast as possible around the Capitol. It has to do what we do every day on Tuesdays. So with that, I ask for an aye vote.
Thank you, Mr. Patterson, and hopefully you can wrap up your time at privacy so that we can establish a quorum and vote on your beautiful bill. Thank you. We will move now to item 7, AB 2198, Flora.
Thank you, Madam Chair and committee members and staff. Today we're going to present AB 2198. In 2022, California, but I love it. California codified federal regulations pertaining to application programs interfacing for
Take it back. This is going to take a while. I think we are just going to end it here, and then I'll provide the updates on Discord once we get the final updates, because they're going to take a while and they still don't have quorum. I know they have to finish up all the other committees and getting their folks back. This is democracy. I wanted to start making food like an hour ago. I need to work out still too. But thank you, everybody. Thank you for joining. I will provide the updates in Discord. If you are not already in Discord, just do !Discord in the chat. Thank you, Matty, for joining us. Thank you, everybody else, for watching and tuning in. Fingers crossed we pass this. Fingers crossed they have quorum sometime soon. So thank you. We will hopefully tune back in for the appropriations hearing, whenever that is, in the next couple of weeks. Until then, take care. Hope everyone has a good rest of your evening. Bye-bye.
Chair and members, Jessica Moran with the California Dental Association. We have an opposed unless amended